Hello, my name is Jason Matthew Fields. I am the Director of Emergency Ultrasound Fellowship at Thomas Jefferson University in Philadelphia, Pennsylvania. This lecture is going to be on some of the clinical applications of bedside musculoskeletal ultrasound, including fracture reduction, hematoma blocks, and arthrocentesis. While there are a lot of potential diagnoses you can make with musculoskeletal ultrasound, this lecture is going to be geared more towards practical applications for the bedside clinician, specifically the emergency medicine clinician. And we're going to look at diagnosis of fractures, tendinopathies, and joint effusions diagnostically, and then also use musculoskeletal ultrasound to help us procedurally, specifically with hematoma blocks, fracture reductions, and arthrocentesis. So when doing musculoskeletal ultrasound, you want to use your linear probe pretty much the vast majority of the time with high frequency and high resolution. And you often may want to use a standoff pad or a water bath to help you, especially when you're looking for your very near field focus. Your technique, you want to hold the probe like a pencil, rest your fourth and fifth digits on the patient so you kind of know where you are and aren't sliding all over the place. If you're scanning any type of area of infection, cellulitis, you want to use a probe cover to contaminate the probe, and scan systematically through your area of interest in two orthogonal planes. And in this example, you might see something wrong with the technique, and what's wrong with this technique is that the sonographer hasn't made himself comfortable. He's kind of hunched over doing the scan, and that's going to be something that will end your career as a sonographer early because you'll put your back out. So raise the patient's bed up or seat yourself, or make yourself comfortable. So talking about a water bath, it's a very nice way to image the distal extremities. The water provides a perfect acoustic interface. Literally all you have to do when you're doing this is have the patient put their hand in the water, and then you can put the probe in the water, and the ultrasound beams are going to travel through the water to the area of interest. You don't need to contact the skin, you don't need gel. And this is especially great for looking at injuries in kids because kids, if they have something that's injured, don't want anybody to touch it or examine it, but they don't mind putting it in a tub of water. So it feels maybe a little bit therapeutic to them. So reviewing the sonoanatomy of the soft tissue, we start with the skin, which is kind of thin hyperechoic line in the normal patient. Below that, you'll see the subcutaneous tissue, which is this hypoechoic region kind of filled with reticular hyperechoic strands. Below that, you'll see the fascial planes, which often you can see some veins, arteries, potentially a nerve, and or other structures kind of running through there. Vessels and nerves tend to be kind of hypoechoic, whereas nerves can sometimes kind of a honeycomb appearance, and they demonstrate anisotropy, which we'll talk about later. The muscle layer comes next. It is hypoechoic and often speckled in the transverse plane. And after that, we can see some bone, which is hyperechoic with posterior shadowing. The muscle often has a different appearance in longitudinal, where as opposed to transverse, it'll appear a little bit more laminar, feathery-like, or we often say pinnate in the long axis. And here's an example of a vessel in the long axis compared to the short. And the short axis is a circle, and the long axis, it turns into a long rectangle. And here's just side by side showing the different appearances of the muscle in short axis on the left and long axis on the right. Tendons tend to have a brush-like pattern to them as all the fascicles run next to each other. So we can see here, they're usually, in typical locations where you would expect to find tendons, connecting muscle to bone or inserting on bone. Here's an example of a knee quadriceps tendon. Here's another example where you can see again the brush pattern of a tendon. Tendons have a feature known as anisotropy. This is a very important feature of tendons and helps you actually diagnose pathology. What this means is since since tendons are very highly reflective, just like a mirror, when you look at it straight on, you get a very vivid reflection. But when you're at an angle to it, you don't get any. You don't see yourself at all. Likewise, in tendons, when you're 90 degrees to the tendon, you get a very sharp reflection. But when you're off angle, it turns hypoechoic. You don't see anything at all. So here's an example of that, with the left image being at 90 degrees and the right image being off angle. So talking about fractures, people wonder why I use ultrasound for fractures. Well, some reasons are it's quick, it's at the bedside. And you can place it over the tendon area, the tender area, and have an immediate correlation with clinical exam. And I find this especially useful in cases where I'm worried that there might be a radiosilent fracture because my clinical suspicion is so high and they have such point tenderness. I could take a look with an ultrasound and rule in the fracture that way. You can also get extra information as opposed to an X-ray, which only looks at the bone. Here you can look at other causes for the pain, such as a muscle tear or a tendinopathy. And it's especially useful in austere environments. We have a global health fellowship where we send our fellows to Sierra Leone, and at their regional medical center there, they actually do not even have an X-ray machine. It's such a poor country that they don't have these resources. So in the clinic, the ultrasound machine that we have is one of the only diagnostic medical imaging that you can find. So very useful for ruling in fractures. So when you compare ultrasound versus X-ray, it turns out that ultrasound is actually better than X-ray for diagnosing rib fractures. It's very similar to X-ray for looking at long bones, especially in the midshaft region, nasal bones, and sternum. And it's inferior to X-ray when you get into complicated bony areas such as metatarsal, metacarpals, proximal femur, and hip. So you want to ultrasound the bone in the long and short axis using a high-frequency linear transducer. Look over the point of tenderness, and also make sure that you do a contralateral examination and compare findings. And what you want to look for is decortication. This is an example of a patient who came in with a clavicle injury, and here we can see that the bone, there's a decortication here in the bone. So there's a fracture. Clavicle fractures have been studied, and this is a pediatric study, and found to have very high sensitivity and specificity in the 95 to 96% range when compared to X-ray. So very easily, this was done by bedside sonographers, clinician sonographers, so easy to do and a good test to rule in the diagnosis. Here's a patient who fell on an outstretched hand and has a deformity, and here we can see a decortication here. This is a left radius here, looking there, and we can see the decortication. This is a Achilles fracture. This was a 24-year-old male who was hit in the chest with a baseball bat, and has, whenever you do your exam, you feel that there is a little bit of a step off there in the sternum. So you take a look at the ultrasound, and one of the things that's useful in musculoskeletal ultrasound is applying a little bit of pressure You have to be careful when you're doing this in a patient with a suspected fracture, but what we see in this image here is the sternum. There's a decortication in the sternum, and it's a little bit posteriorly dislocated. There is a little bit of periosteum intact here. You can kind of see bridging between the two fracture fragments. This is a patient who fell on their side and had a lot of rib pain, normal chest x-ray though. So clinically suspected for a rib fracture. Wanted to be able to make the diagnosis just to tell the patient what to expect and how long they would expect to have pain, and use an incentive spirometer for. So we took a look here. This is the long axis view of the rib here, and we can see decortication there and there. So diagnostic of a rib fracture. This was a case that I saw with my resident, and the patient had clinically what appeared to be a shoulder dislocation. However, when you examined the patient, it didn't seem quite right. The resident was eager to get this arm reduced and setting up for the procedure when we decided to, let's make sure that this isn't not a fracture, and taking a look, it was very easy to see this decortication and rule in a humerus fracture. When you look at it in transverse, you can see the drop off there between the two fracture fragments. So I often like to think of ultrasound as like my own bedside fluoro. It can be used for procedures, fracture reduction, shoulder dislocations, and foreign body removal. And the advantage is it's quicker, smaller, less bulky, simple. You don't need an additional technician, and there's no radiation. So here's a case that I saw not too long ago in the ED, a patient who has a fallen and outstretched hand injury. And when we did the ultrasound, we saw you could see the fracture dislocation there. And so we had a couple issues we needed to deal with. One is we need to control this patient's pain, and two, we need to reduce the fracture. And so my algorithm for this is to an ultrasound-guided hematoma block followed by an ultrasound-guided fracture reduction. So the ultrasound-guided hematoma block is very simple to do. You basically identify the fracture site and aim the needle for that area. You make sure to see if you aspirate any blood, and then you infiltrate with a local anesthetic. A lot of different recipes for this, but 15 mLs of 1% lidocaine works just fine. Basically what happens is as you inject into that fracture site, the broken ends of the periosteum will absorb that lidocaine and anesthetize the periosteum and surrounding tissue. And so after doing this, we were able to manipulate the patient. One thing that's recently been reported is you can also do a supracondylar radial nerve block for this kind of fracture reduction. This was a case report, so something that's kind of new, but is also potentially useful. So after we did our manipulation, we checked again, and you can save your initial image and scroll, and then save your reduction image and flip back between the two to kind of see how you did, or even use a split screen. But when we compared our before and our after, we felt like we had a pretty good reduction of this distal Achilles fracture. And so then we splinted the patient and sent for a repeat x-ray and felt like it looked pretty good and sent the patient home. Here's another example of a patient that had a comminuted fracture. You can see the displaced fracture fragments here on the left. And over on the right, this was after reduction. So this has been studied, and it's been fairly well validated, and improves actually the reduction, the need for repeat manipulation, which is a very painful thing when you have to send the patient to x-ray, then you find that it's not a good reduction, bring them back, re-anesthetize them, and do another procedure again. A study in pediatric population found that ultrasound had a very good sensitivity and specificity for diagnosis, and success of reduction using ultrasound guidance was high as well, 92%. So moving on to tendinopathies, we're going to look at partial tears, complete tears, and talk about tenosynovitis. Again, here we see the brush pattern of the tendon in this example. And again, just to repeat the point earlier about anisotropy, here we see a biceps tendon going through the bicipital groove, and as the sonographer is rocking the probe back and forth, we can see this tendon light up and turn dark, and that's because the angle is changing from 90 degrees to more or less than 90 degrees when it turns dark. So this is important because if a portion of the tendon remains hypoechoic, despite being at a 90-degree interface, that suggests that there is tendon damage there. So here's that again. So a tendon that I like to look at in the emergency department is very easy, readily available, is the Achilles. Here is a very normal looking Achilles tendon. We're starting superiorly. We see the feathery-like appearance of the gastrocnemius muscle. Above that, go back here, above that we see the takeoff of the Achilles tendon traveling and going in and inserting on the calcaneus back here. So the reason I like to use this in the emergency department is not really to diagnose a complete Achilles rupture. Those are actually usually very obvious clinically, but actually to look more to see if the patient has a partial Achilles rupture, in which case splinting the patient might be useful in expedited follow-up with orthopedics. So here's a case of a 35-year-old male who stepped into a hole and heard a pop, and he was very tender over his Achilles. He had a normal Thompson test. In other words, whenever you squeezed on his gastrocnemius muscle, he still had intact plantar flexion of his foot. So it's not clinically a full rupture, but highly suspicious for a partial rupture. So the first thing I would say is it's nice to look at the normal unaffected side, and here we see a nice brush pattern running through started from the calcaneus there all the way up to insert on the gastrocnemius. Sorry, I apologize, the image is a little bit dark. But on the affected side, we see something different. We see kind of a more heterogeneous picture where the tendon is, and this is due to there's some hyperechoic bleeding as well as swelling of the tendon and some loss of anisotropy. So this is suggestive of a partial tendon injury. And I'm going to show this in short axis. It might actually be a little bit easier to see. Here we see in short axis that the normal side is the tendon is very tight bundle, and over on the affected side, the tendon is swollen, enlarged, and has a lot of heterogeneous appearance to it, with some hyperechoic bleeding, and again loss of anisotropy. Here's another example of a tendon, and as you scan down, you can see down here there is a fairly smooth brush pattern, but up here we have all these hypoechoic areas and loss of anisotropy, suggestion of a partial tendon injury. This is a patient that had a hyperflexion injury of his right knee, and on the unaffected side on the left here we see that the patella here and the ligament is, the patellar tendon is intact with a smooth brush pattern. But over here we see we don't see that smooth brush pattern, and we see just kind of a lump mass here at the base of patella. So what we have here is a complete patellar ligament disruption. So another thing I like to use this for is a bedside tendon exploration. So here is a patient that had a fracture but also had a laceration over the fracture. So the question is was the tendon, overlying tendon of the bone there also injured? So oftentimes, traditionally, we would anesthetize this and explore this at the bedside, which was done in this case, but we also took a look sonographically because no matter how much you explore, it's very difficult to visualize the full tendon. So whenever we took a look sonographically at this patient, we felt like the tendon looked well intact. So here we see the laceration, here we see the fracture, and in between we can see it looks like a nice healthy tendon there. And in this case, what we actually believed happened was this was blunt trauma, so this was more of a break in the skin from blunt trauma, and the pressure had probably caused this fracture, but there wasn't actually a true laceration from the laceration to the fracture, and I think that's well demonstrated here by this ultrasound. This is the same image, just having the patient clench his fist to recreate the position that the fist was in when the injury occurred. This gives us, causes the laceration to be much more overlying the fracture, kind of recreating the position of injury. This is a patient with intense pain, flexion posture, swelling, and percussion tenderness. Clinically worrisome for tenosynovitis. And you can see that on ultrasound. This is using the Waterbath. You can see the tendon running through there, that nice brush pattern, and you can see fluid around it. It's another example of tendons with fluid surrounding them in a Flexor Tenosynovitis case. And sometimes you can just make other alternate diagnoses, in patients. So here's somebody who had blunt trauma to the right arm, had a lot of pain, a lot of focal tenderness there and swelling, and a negative x-ray. And when you look with ultrasound, you can kind of see the muscle tissue over here, and in the middle you can kind of see this fluid collection. There's a biceps intramuscular hematoma. Here is another patient that I saw with one of my residents who was worried. This guy had been trying to step up on a ladder, heard a pop in his and had gotten pain and swelling in his calf, but she was concerned that could it be an Achilles injury. Clinically, when you look at this, you're not too suspicious of at least a complete tear, because this tendon, Achilles tendon, does look intact, but there is some calf swelling that's appreciable. So when we ultrasounded his Achilles, they look completely normal, but when you looked up in that calf region, you could see a intramuscular hematoma tracking in between the gastric and soleus muscle. And so that was the diagnosis there. So effusions, a common emergency department complaint is a hot swollen joint. Here we have a 67-year-old male with an atraumatic right ankle pain, erythema, and swelling. And while my practice do a lot of knee arthrocentesis, ankles, wrists, shoulders, hips, those are joints that I don't tap on a day-to-day basis, and so they can be very difficult and challenging. So we often struggle with the question is, whether we should even tap or not. Are we going to get fluid out? And where should we go with the needle to make to be the most high yield spot? So ultrasound can help with both of these. You can really identify whether a tappable effusion even exists, and it can help you guide the procedure. So like other fluid collections, joint effusions appear hypoechoic or dark. This is a knee, and they're easily identifiable. So here is an ankle effusion. We're looking here at the tibio-talar junction on the left, and that's a normal one where we don't see any fluid collection. And on the right, we can see an ankle effusion, easily tappable. This was an example of a wrist. Clinically, this was very difficult to determine whether there was a fluid collection, but sonographically, we can see it very well. It's not very large, but potentially able to drain some fluid from it. And here's an example of a hip, which is very, very difficult to determine if there's an effusion there. but here we can see it sonographically. This was an MTP joint effusion. And so whenever we do arthrocentesis, I like to say that there are 3 steps. The first step is identify the effusion. The second is to take measurements. And the third is to choose either a guided or landmark method. So first we have identified the effusion. Here we see the femoral head, femoral neck, and we see a hypoechoic effusion anterior to that. So then we want to take measurements, and we can measure the size of the effusion, but more importantly, we also want to measure the distance to the effusion. So you can see in that right side image, that's the difference from the skin to the effusion. And this was important in this case because it made us realize that this effusion was over 4 centimeters deep, so requiring even a longer needle to reach it. And then you want to use either the landmark technique, or you can do an ultrasound guided technique. The landmark technique is to make pin markings where you saw the effusion, and then go back to your traditional tools and method to actually do the arthrocentesis. I like to advocate this method because it's simpler for people. Holding the ultrasound probe and trying to watch the needle under ultrasound guidance can require a lot of dexterity, and often people might lose the needle tip. So at least doing it this way, you're cognizant of how deep your needle's going. And you can always, if this technique isn't working very well and you think your needle may have gone in the wrong place, you can always leave the needle in and pick up the ultrasound probe with a sterile cover and put it back adjacent to the needle to see where your needle tip is and how close to the effusion it is. You can also do the ultrasound guided technique. Here's an example where we can see the joint and see the needle tip, you know, kind of coming into that effusion and where it's draining. So here's a study done to look at patients with joint pain, swelling, and erythema, where there might be concern for an effusion, and they asked the treating physician what the likelihood of an effusion prior to ultrasound was. Then they performed the ultrasound, and of 54 patients in which aspiration was initially planned, aspiration was initially planned in 39 cases prior to ultrasound and only 20 cases after. So showing that a lot of times you might think there's a joint effusion when actually a tappable effusion doesn't exist. So this really cuts down on the amount of unnecessary procedures we're doing, time spent, and potential complications. This was a study looking at bedside ultrasonography to identify hip effusions in pediatric patients. Here's a picture showing the femoral head, the anterior surface of the femoral head, and the posterior surface of the iliopsoas muscle, and that's where the effusion will develop in between those two. They found that this had pretty decent sensitivity but much higher specificity, so a nice rule-in test that can be done easy by bedside clinicians. So pearls and pitfalls of musculoskeletal ultrasound. You want to make sure you communicate with the patient, find the most tender region, always do a contralateral exam to look at a normal versus abnormal, although you have to keep in mind that there's always the possibility that the patient might have bilateral pathology. Not too common in the emergency department, but can happen. Pitfalls are, trying to look at fractures in difficult places like the wrist and the hip. It might lead you to have a false negative. Failure to create a 90-degree angle of insonation with the tendon, making you think that there is tear when one actually doesn't exist. And failure to fully evaluate a joint space. So especially when you're ever looking for an effusion, you may miss it if sometimes the effusion is hiding out more posteriorly than where you were looking. And inappropriate gain settings are often an issue with musculoskeletal ultrasound, making you miss a fluid collection if the gain's too high, or not visualize a fully intact tendon if the gain was too low. And that concludes this lecture on musculoskeletal ultrasound.